Hi everyone, welcome to our 8th webinar in the Advocates and Allies series, Homelessness and Mental Health, Systemic Change for a Better Future. My name's Carmel Tebbutt, I'm the CEO of the Mental Health Coordinating Council and I'll be your host for today. I'd like to begin by acknowledging the traditional owners of the land that we're meeting on. For me, that's the Gadigal people of the Eora Nation, but of course it will be different depending on where you're zooming in from. And I want to pay respects to elders past, present and emerging. I'd also like to acknowledge the contribution of people with the lived experience of mental health conditions and the difference that they have made to our understanding of mental health issues and the need for reform. The Mental Health Coordinating Council is the peak body for the community managed mental health sector. We advocate on behalf of the sector. We hold events such as these to help support the sector go about the work it's got to do. We're also a registered training organisation. So this webinar is part of our Advocates and Allies series, where we aim to provide a better understanding of the broader mental health and human service system for frontline mental health workers in the community sector. So I'd like to welcome our other presenters for today, and I'd ask them to turn their cameras on. So we have Trina Jones, who is the CEO of Homelessness New South Wales. Welcome, Trina. We have Shane Jakupec, who is the Senior Operations Manager at Neami National. Welcome, Shane. Thanks for joining us. And we also have John Mason, who's the Lived Experience Consumer at Neami National. Welcome, John. Thanks for being a part of today's webinar. So we're due to finish at 3:15. The way the webinar will run is that we will have our two presentations from Trina and Shane. We'll then have a panel discussion where we'll be joined by John on the panel as well. If you've got any questions for the panel discussion or for the presentations, please put them in the Q&A chat function, or not the chat function, actually, the Q&A function. I'll be keeping an eye on that and I'll be able to put those questions to our presenters and the panel. So do that on the way through the presentations or wait till we get into the panel discussion. So I'd now like to move into our first presentation. And our first presenter, as I said, is Trina Jones, the CEO of Homelessness New South Wales. Now, Trina has had over 15 years experience leading responses to complex social issues. She started her career in youth justice and she has worked in Australia, the UK and Ireland. And amongst Trina's many achievements, she led the development of Sydney's 10-year homelessness action plan, the emergency response protocol for people sleeping rough, and the homelessness assertive response team. Trina was a highly commended finalist in the Australian Institute for Disaster Resilience Awards. And today, Trina is going to talk about Homelessness New South Wales Ending Homelessness Together campaign and the research that they've conducted into how people who are homeless experience the service system. So thanks very much, Trina.
Thank you, Carmel. I would also like to acknowledge the land I'm coming from today and pay my respects to the Darrow people and extend that respect to our Aboriginal colleagues on the call and elders past, present and emerging. So I'm going to focus on the intersections of mental health and homelessness in New South Wales today. And as we were discussing prior to this session, this is an enormous area of concern and an area that's really strongly interlinked and something that we must consider in tandem when we think about appropriate and adequate responses for people at risk of or experiencing homelessness. So I'd like to talk a little bit about who we are first. So Homelessness New South Wales are the peak body for homelessness in the state. We exist to build the capability of people and the capacity of systems to end homelessness. We have a vision for a future where everyone has a safe and secure home and connection to community. We represent over 190 members made up of specialist services, allies, change makers, and people with lived experience working to end homelessness. When we talk about ending homelessness, what that means is that it is rare, brief, and non-recurring. And we know that this is possible, not because this is an aspirational statement, but because specialist homelessness services and allied agencies support people out of homelessness based on that person's resilience, as well as that support every single day. So we know that this is possible, and that's why we set our goal as ending homelessness. So when you think about homelessness, I'm not 100% sure who's on the call. So taking us back to a shared understanding is important for this conversation today. So normally when I talk to people about people experiencing homelessness, they immediately think about people sleeping rough. The reality is that people sleeping rough represent just the tip of the iceberg of people at risk or experiencing homelessness in New South Wales. They represent just about 7%. The rest of the people below the iceberg are people who are living in crisis or temporary accommodation. They're couch surfing, they're in overcrowded accommodation, they're living in boarding houses, or they're experiencing extreme rental and mortgage stress or risk of homelessness. I'm going to talk to you a little bit about why are we seeing the number of people who are homeless in New South Wales. And then I'm going to talk to you about some of the intersections with mental health and some of the responses that are the best practice ways to ensure that people with mental health conditions are properly supported to sustain their tenancies and not become or stay homeless. So you will all know there's a growing number of people in need. Recent disasters have left thousands of people homeless. Last year, over 68,500 people were supported by a specialist homeless service. Of those, approximately 4,000 people were supported a month who had a mental health condition. Now, while services are seeing, close to 70,000 people, a further 50% of people who sought support couldn't have their assistance needs met. So we know that our services are operating way beyond capacity. In many cases, we're seeing 50 or more % capacity. And that means that they're operating beyond the resources that they have available to them. And they're doing that based on the goodwill and, the energy of staff who are working longer hours and are there based on their motivation and their compassion. But we know this is a huge risk for our sector and for the support of our clients too. And so even with all of that additional work and even with services going above and beyond day in, day out for years on end, still we have 50% or 49.9% of people who sought support can't get their needs met. And that's the highest rate of turnaways in the country. And so why is this the case? Well, we can't end homelessness without housing, and housing supply is not delivering for those in need. There are currently 57,000 households on the New South Wales housing waiting list. Many of those face a 10-year plus wait. But the reality is, with the investment of social housing in New South Wales, the wait will be much longer. I'd just like to make a point on that. So every year in New South Wales, about 70,000 properties are approved to be built. For many reasons, only 35,000 of those residential dwellings are actually built. So of those 35,000, only 2% or 700 are actually social housing properties. Now, at that rate of investment, it would take over 80 years to ensure that everyone has a safe place to call home on the New South Wales housing list. So we know that there's a significant shortage of social housing, and the safety net is not what it was and is atrophying over time. At the same time as we have inaccessible rental market, as being described as depression era scenarios around the rental market with thousands of people in rental stress. The aftershock report that we commissioned with NCOS and other peak bodies across the state shows that post-COVID, 54,000 people were in rental stress. And I understand recent research by CHIA and the UNSW Future Centre has shown this number is even greater. And so with less than 1% affordable vacancy rates, if people can't go to social housing, they're also locked out of the private rental market. And so at a time when services are seeing more people than ever, and we have very limited places where people can go, we do not have the investment to respond to the growing demand. So the New South Wales government currently spends $1.2 billion in total on housing and homelessness. Now, of this spend, approximately 420 million goes to the front line, goes to the services who are there to support people when they're in crisis. Now, if you break that down to how much is spent per person experiencing homelessness, it's just $42 a day, or almost $43 a day. And a question that I would ask is $43 a day enough to support a person out of homelessness? Well, we know that even though services can achieve this, it's not enough. And at the same time as we have the second lowest investment in services after the Northern Territory, we have the second highest rate of homelessness across Australia. So the clients that are being supported $42 a day are the same people who cost an additional $31,000 per year in peripheral services like health services and like justice services. So in reality, we're spending more money to keep people in the system than we are to get them out of it. And so I wanted to give you an overall picture of what's happening for homelessness across the state. And when we think about the intersections between homelessness and mental health, the key takeaway that I want us all to focus on is that homelessness is both a cause and a consequence of mental illness or mental ill health. So how prevalent is mental ill health among those who are experiencing homelessness? So we know the Journey Home survey and AIHW data can tell us some of the insights about who's using services and what they're reporting. But I would caution to take these stats with a pinch of salt, because we know that mental health is widely underreported and people still feel like they can't share what's going on for them. Many reasons are because of that, maybe their own personal view on that, but also the way that they're treated by the system if they disclose they have a mental health issue. And so while we know that there's high rates of mental ill health diagnosis among people accessing specialist homelessness services, we still think this number is probably higher. So we know that if a person is in chronic instability or in homelessness, they show much higher rates of experiencing mental ill health than people who are in what would be referred to as kind of stable homelessness with staying with friends and family groups. So there's an interesting intersection between loneliness, isolation, and how a person experiences their mental well-being as well. Nationally, of people who are accessing SHS services, specialist homelessness services, about 31% report having a mental health condition. And of those 31%, over 40% also experience domestic and family violence. The majority of people who use specialist homelessness services are women, and the majority of people reporting mental health issues are also women. What was interesting and frustrating at the same time is nationally, and the same across New South Wales, the majority of people who have a mental health condition are returning to services over and over again, year after year, and they're not getting that availability of support they need to exit homelessness long term. So about 71% of people who access specialist homelessness services are recurring homelessness episodes, and they have mental health conditions. So does experiencing housing stress or homelessness impact mental ill health? Well, we probably don't need a study for that. It's common sense, of course it would. Being under that level of pressure and stress and not being able to secure a roof over your head or a safe home for yourself or your family is extremely stressful, and it's extremely traumatic. But the evidence is also there to support the idea that any of these environmental exposures to this extreme and chronic stress can and does lead to mental illness. So the Journey Home survey that Ahuri commissioned identified that for those who were homeless before they developed a mental illness, the onset of the illness occurred on average 9 years after first experiencing homelessness. So this has a long tail, okay? So it's not just a case of I've been through this crisis and now I'm on my feet. We have to continue to support people because we know that they can have ongoing and compounding trauma from their experience of homelessness, as well as experiencing homelessness because of trauma. So there's huge intersections here that we must consider in our responses to ensure they're person-centered and meeting people's needs where they're at. It's also interesting to note that for those experiencing homelessness, mental health developed at much an older age than for those whose mental illness was present prior to becoming homeless, or for those in the general population. And for those who have time, I'd recommend reviewing that study. It's very interesting. So there are many challenges, and I probably could have done a presentation on just the challenges, but I wanted to draw out 3 specific challenges today. First is exits from hospital. So 1/4 of all people admitted to acute mental health services are homeless prior to admission and are mostly are discharged back into homelessness. So we have a huge issue of people exiting institutions, particularly hospital settings, into homelessness. And while we have some great examples in New South Wales of unique projects and services that respond to that, like the homeless health team at St. Vincent's Hospital and partnerships with Neami and others, across the board, we do not have, 1, the data that tells us who's exiting a hospital into homelessness, and 2, a robust enough support system to ensure that people, that this isn't the case for vulnerable people. We also know that services are not funded with multidisciplinary teams to meet the complexity of need that they're dealing with. And this includes assertive outreach. So when we talk about multidisciplinary teams, I'm talking about your social worker, your clinician, your mental health support worker, even to the broader extent of nutritionists or physio or OT services. And so in crisis accommodation settings where there are compounding traumatic and crisis mental health situations, those services are not funded to have clinicians and specialist responders on site, with the exception of a few that have very specific funding to meet the needs of people with complex mental health issues. But in the broader group of specialist homelessness services, those positions are not funded, and they are critical to the trauma-informed response. The other issue we hear time and again is a lack of services in regional areas where we have specialist services having to wait and drive for hours on end to try to access mental health support, and really having to see people cascade into very harmful situations for themselves and for others before they are responded to. So it's very challenging for the allied services, and it's very challenging for those on the front line, but extremely challenging for those experiencing the mental ill health. So I want to talk to you about a couple of models that work well to respond to people who have experienced complex issues in their life. So we're talking about when you might have a mental health issue, you might be using substances, a history of trauma, and you may have other compounding needs that need to be responded to. So I'm sure many of you on this webinar will be familiar with Housing First. I won't overly labor that, but if you haven't heard about it before, it's basically a model that supports a person into a house first and wraps the support around them to ensure that a person can succeed to thrive in their home. Traditionally, the process was around, you'll notice the kind of, the transition to the home model that looked at a person is homeless, they then go into temporary accommodation, they then go into a crisis service, they might then be transitioned to a transitional housing property for 12 to 24 months, and then they may be transitioned to permanent housing. And so the Housing First model looks at, well, how do we just put a person in a house first and wrap all the supports around them? And this is an evidence-based model that is demonstrated time and again to work most successfully for people who have experienced complexity and are experiencing complexity in their own lives. So internationally, this model, I just thought I'd draw out a couple of examples where a person's been able to sustain their tenancy. In Portugal, 83% at 1 year. You can see in the Netherlands, 5.5 years, 77%. Denmark, high rates after a year. And in the New South Wales example, Together Home, we see 80% sustain their tenancy 6 to 18 months into the program. Now, this is compared to evidence for this particular group of 30 to 50% success rate when the pathway follows that staircase model. So again, when I say this particular group, I'm talking about people who are experiencing complexity, who have mental health issues, potentially substance use issues, and have one or more personal challenges that they're working to overcome. And so the evidence around housing first is very focused on ending long-term homelessness for people who have been experiencing homelessness for a long time. There's a couple of questions in the chat. I don't mind. Oh yeah, we can come back to those at the end. I agree with that also. So in terms of housing first in New South Wales, everyone will be familiar with the Together Home programme. This was a significant investment by the New South Wales government, largely came to a head through COVID, and I'm sure Shane will talk to this in more detail as he's very close to it. The aim is supporting over 1,000 people from the street to home into stable accommodation linked to wraparound support. And so this model is hugely successful. I suppose the challenges are that it relies on a head lease, which is basically the government rents privately because we do not have the stock of social housing, the government funds community housing providers to rent privately until they then have the stock available to support people into a long-term accommodation option. And that has become increasingly more difficult over time as the rental market has gotten tighter and tighter. But this program has proven to work, and can only work if there's sustained investment in the support for people who are living in the supported housing. Now, at Homelessness New South Wales, we are funded separately to facilitate and manage the delivery of the Together Home high needs packages. So this is really about if a participant has a high degree or is experiencing a high degree of complexity, community housing providers can make a referral to the assessment panel, which is made up of a multidisciplinary team of people, including people with lived experience, and they make a request for funding to the high needs package, and then we review that alongside the panel, and Homelessness New South Wales is the convener and the facilitator. We're not a decision maker. The panel make the decision, and then we expend the funds. To date, there's been almost $3.8 million allocated to 162 people through initial referrals, reviews, and one-off grants. And over 33% of the funding has been allocated to Aboriginal and Torres Strait Islander recipients. Of all of the funding that's been allocated, about 50% is for people to support people's recovery on mental health conditions and support people to access specialist support. So what's happening is you've got a DCJ funded program administered by the Peak, filling the gap in mental health support for the most vulnerable in our community. So that's one of the programs that are operating in New South Wales at the moment. So we've got a Housing First program. The other policy lever that you may be interested in is the Housing and Mental Health Agreement. That's an agreement that's being derived by New South Wales government, where health and housing are working together. And it's really about making sure that people who live with mental illness have timely access to safe, secure, and appropriate housing and mental health supports in place when needed to sustain housing and to live well in their community and lead their recovery. And this is, a very strong aspiration that we strongly support. And obviously there's a way to go here with the HAMA, and we've seen previous iterations of this, but the current model is quite robust in its ability to work with existing networks on the ground and identify system blockages, referring that back to a decision-making committee at a senior level in New South Wales Health and Housing. So we are a member of one of the committees, and we hope to influence that process as much as possible. We started by consulting with over 95 specialist homelessness services about how we could make the HAMA better. And broadly speaking, people supported the coordination, the governance, and the accountability mechanisms, but really saw huge policy gaps in the need for whole of government approach to mental health and housing, and also some challenges with the practical implication of the frameworks due to resourcing shortages, particularly in regional and remote New South Wales. So when we look at ending homelessness for people with mental health conditions, what might that look like? Well, it looks like addressing root causes and building community connection. And that's making sure that people have access to the types of services that they need in place when they need them, where they live. And we have a far way to go, everything from risks around transport access to response times, to having to only get support when a person's needs reach such a level of complexity that they're harm to themselves or others, are significant barriers to supporting people. And we know that we need to have investment not only at the acute response stage, but way upstream in community centres, in libraries, in family groups, in mums and bubs groups, to support people who maybe have mental health conditions and need that initial support from community. So we need to think not just about homelessness services and the homelessness system, we need to think way before that around supporting young people, older people, right across the spectrum, right across the cohorts, to make sure we can have in-community connection and support. And that looks like early intervention and prevention work, as well as community-based responses. We also want to ensure that there's no exits from hospitals into homelessness. And we're really strongly advocating for this, firstly, to be recorded, because nobody's even recording this at a way that we can draw the data out. And secondly, that we have better coordination between specialist homelessness services and hospitals to prevent people from falling into homelessness. And we support housing first programs and in-home support programs like HASI, which I think Shane will talk more about, so I haven't got into, but home assistance support programs that can help people to sustain and retain their tenancies long term. So all of this requires us to have bold vision for change. And when we think about, how do we respond to ending homelessness? Traditionally, we've relied on the government-led strategy. So we'll see what the government puts out, we'll be involved in a couple of consultations, and then we'll follow along with our service delivery through our contracts and also with the government-led responses. So we're actually trying to look at how can we change the way we do this? How do we redesign the plane while we're flying it? And we are working on developing a systems change strategy. So this is about co-designing and developing a 10-year shared vision for how we as a sector, as allied services, want to end homelessness in New South Wales. And how can we mobilise and align our efforts? So how could we achieve this? We're developing a shared vision and collectively identifying systemic conditions that hold the biggest challenges of homelessness in place. So what does that really mean? So we know that there's big drivers of homelessness like poverty, gender-based violence, lack of access to social and affordable housing, family breakdown, lack of access to health and support services. But we also know that there's lots of conditions that are holding these things in place. Our policies, our practices, some of the mindsets, the power dynamics, the resourcing flows. And what we want to do is identify collectively, how can we work together to change those things? So imagining all of those policies, mindsets, etc., holding things in place, how can we leverage those things to make change so that we can get better resource flows, improve our policies and practices, improve our and change some of the mindsets that retain homelessness in New South Wales. And so we've started with people with lived experience. We've started talking to, I think we've almost spoken to nearly 25 people now. We continue to grow that. We've spoke to people on the front line, service leaders. We're talking to health practitioners. We're talking to people who work in banks but are interested in homelessness, people who work in the front line of different types of services that are interested in supporting homelessness. And we're saying, how can we end homelessness together? And what role will you play in that? And how can we action independently aligned activity to make change in New South Wales? And so we're actively working on this, and we're hoping to have our kind of draft plan that we've heard from the ground up ready for people in the next couple of months to comment on and give feedback and participate in. So if you're interested in being involved in that, we would love to talk to you, and I'd encourage you to please get in touch with myself or my colleague Amy at Homelessness New South Wales. And I can put my email in the chat. And so really wanting to challenge some of the opportunities to integrate our responses across whole of government so that we have a whole of community response across government services, allied services, engaging people with lived experience in the process so that we can end homelessness together and ensure the well-being of people who have mental health conditions. Thank you very much.
thank you, Trina, for that extraordinary presentation. I mean, some of those statistics are both, alarming and really underscore your final points about the need for a change in strategy, a change in the way things are done, and a call to action. So we do have some questions in the Q&A and in the chat. I might maybe pose a couple to you now because they're specific about what you're presenting on before we move into Shane's presentation, if you're happy for that. But we're not going to get to all of them, and we may be able to cover some when we get into the panel discussion. But one I think is quite interesting. Do you think there needs to be greater training and development for real estate agents and landlords in understanding trauma and mental health conditions to prevent evictions of people placed in private rentals?
I love that I got asked that question. I'm actually presenting to 500 women in real estate next week to talk about how they're also on the front line. And so within our sector, we can sometimes go, well, you don't know enough about it, so you're not welcome to be part of the solution. And that's not something that people necessarily say, but people can be excluded from responding because there is concern around vicarious trauma. There's concern that people who are at risk get the best possible support, of course. But I think there's absolutely opportunity to skill up people who find themselves on the front line. You know, the kind of idea of the accidental counsellor is called in the mental health space, or the accidental responder, and ensure that those people are equipped to respond with compassion, because we know that the real estate agents are the ones that will see the people who are at risk and struggling and could work with our specialist homelessness sector to prevent people from becoming homeless in the first place. Because much easier to pay rent arrears and support a person to sustain their tenancy than it is to help a person to, re-enter the rental market if they've fallen out of a tenancy or ended up at NCAT.
Yeah, absolutely.
Yeah, I agree. Definitely need more training, and I hope that's the first step towards that.
Yes. And I might just mention, I mean, it's not private real estate agents, but Mental Health Coordinating Council have been working with CHIA on delivering training for frontline community housing providers and their staff. That's been really well received training around understanding the needs of people with mental health conditions and where to get support and help. But the private rental market is yes, another step. So that's great to hear that you're doing that presentation, Trina. I don't know if you can answer this, but someone's asked a question about whether there's any data on the influence of Airbnb on renting housing availability.
Well, if you're interested in that, I direct you to our website. I recently gave evidence to the Independent Planning Commission about the impact of short-term rental accommodation on increasing rates of homelessness in the Byron Shire, but more broadly across New South Wales. I could talk on that for another hour if I had the time, but if you're interested,
go to the website. That's a
jump on the website and have a look at our submission. And as always, if people want to discuss any of those issues further, please don't hesitate to contact me.
And then maybe just a question. Someone's asked, what constitutes a high needs package, and what would you consider a long time for people to be experiencing homelessness?
Sadly, we've seen people experiencing homelessness for 17 years. Like, I've in my role when I worked more closely with Shane, doing assertive outreach in Sydney, we met people who've been on the streets for, more than 10 years, which is a shame and indictment on our society that we have vulnerable people in that situation for so long. It can happen for a long time, I would say. Yeah.
Great. Look, thank you so much. Oh, yeah, the high needs. Sorry.
So with the high needs package, there's very kind of strict criteria around that, around the person needing to have, a number of factors that contribute to their complexity, but we do take it on a case-by-case basis. So if you're representing a CHP that's got together home, please reach out. Yep.
Great. Thank you again, Trina, and we'll have you back when we get into the panel discussion. That was a great presentation. Thank you. So our next speaker is Shane Jakupec, and Shane is the Senior Operations Manager at Neami National. Shane delivers a range of homelessness, suicide prevention and mental health services in New South Wales. Shane's also worked as a trainer and in service development, and is a foundation board member of the End Street Sleeping Collaboration. So Shane's going to talk about how Neami supports people navigating the complexities of homelessness, mental health and co-occurring difficulties, and how their needs are best met. So thanks very much, Shane, for being a part of the webinar today.
Thank you, Carmel, for that introduction. And just to kick myself off here, I would also like to acknowledge the Weagle people on Darrawah land in Sutherland Shire. Pay respects to elders past, present, emerging, and anyone who might have Aboriginal and Torres Strait Islander heritage on the webinar today. Thanks for being here and having me here. I've been working in the mental health sector basically my whole career, well over 20 years, and the last 10 of those years has also been running programs in the homelessness sector. So I feel like I've had a pretty good view of how those sectors work from the inside, how contracts are developed, and how they can help or hinder the other and impact each other. Some of my early work in the early 2000s was seeing the development and evolution of the Housing Accommodation Support Program, or HACI, which Trina hinted to before. It was really at the time when it began, it was a homelessness response for people with mental health and psychiatric issues needing to exit hospital that did not have housing. And the original model actually provided properties for the individuals, as well as quite well supported support packages for people to be able to move into. And some of the key criteria around that, there were long-term support, there were long-term housing, and they were the right ingredients to support many, many people out of hospital, not onto the street, but into their own home and to live meaningful, fulfilling lives. That program has gone on to be very successful, and there was a recent evaluation that you could dig up, which talks to some of the outcomes and cost benefits to government, but also the outcomes for individuals that are utilising that program. And it's a really good starting point to say that we've had for 20 odd years now, that program almost has been running and operating very well, yet we still have a sector, or sectors I should say, that are quite disconnected from each other. And really some of the information I'll provide with you today is really highlighting some of the things that are working and have been working and really just need to be scaled up. We know lots of the things that work. We don't need more pilot programs. We need to just actually scale up a lot of the things that are already working. So I guess some of the programs in homelessness that I've worked in, I've sort of worked across the spectrum of services, from assertive outreach, as Trina mentioned earlier. That's getting people from the street into a house of sorts. It could be temporary accommodation, it could be crisis accommodation, in programs where we've supported people into long-term housing and support, but also I've worked in the space where it's in a bit of an emerging space around sustaining tenancies. So identifying people who are at risk of losing their tenancy and ending up homeless or homeless again, and putting some interventions in place to actually support them to not become homeless. And that's there's some really promising work in that space now. I guess what I've learned from my time in the two sectors is that there is this really dire disconnect between typically health and housing services when we think about the sectors, and people experience differing responses and differing outcomes depending on where they enter. Many of the programs that are funded in the health side are actually really good programs, but the criteria to access them are really high because they cost quite a bit of money. They have great outcomes, but the majority of people that are accessing specialist homelessness services can't access them. And some of the other programs on the housing side, I guess, again, are not scaled up or are shorter term and not really providing that long-term permanent housing outcome that people need. One thing we do know is that when action's required around health pandemics, we all remember COVID, money came flowing and many thousands of people around Australia moved off the street into hotels to be able to isolate from COVID, and then were supported to move into longer term housing. And so unfortunately, we've had a little bit of a slide back because the intensity and the need from a health perspective is not as great. And so we're reverting back to a place where you know, those quick, rapid options for people are just not being put in place as effectively as they need to be. So what I've seen and what I do know needs to happen is that where the systems can work together, we can see real life-changing, tangible outcomes for individuals. Because what I'll talk through now, I guess, is a little bit about mental health and homelessness as we see it, and some of the impacts that has on individuals. So if we think about the prevalence of mental ill health, so for people that are homeless or in the homelessness population, the Specialist Homelessness Services sector nationally has identified that about 27% of people across Australia typically would identify as having a mental health concern. Now, that sounds quite low, but that's, we're talking about everyone on the housing lists, anyone accessing a specialist homelessness service, not specifically a housing service. When we look at, in 2015, there was a registry week in Sydney, which identified as many street sleeping people and people in crisis accommodation and conducted a survey with them to assess their needs. That identified 53% of people having a mental health concern. In 2019, also in the same area, another survey was done, and that actually jumped up to 75%. And Neami was involved in South Australia in a project called the Adelaide Zero Project, and that was about supporting rough sleepers into housing directly. And stats from that, where people were street sleeping, were as high as 81% of people identifying a mental health issue. So the long and the short of that is, the more insecure your housing is, the higher the prevalence of mental ill health, or the likelihood that you will have and be impacted by a mental health issue. So I'd like you to ponder the reverse. Imagine if there was secure housing for everyone, that would mean that there would be less prevalence of mental illness across our communities. And really, the barrier to that is housing. And you know, we hear that all the time, lack of housing, but it is really one of the biggest issues out there, because where we see programs that there is housing and there is support for the people that need it, we have amazing outcomes occurring. I mentioned in the intro, as mentioned, I'm a board member on the End Street Sleeping Collaboration in Sydney. The End Street Sleeping Collaboration identified through their surveys that when we're looking at the well-being of people that are street sleeping, we shouldn't just be looking at mental health either. We saw huge numbers of people that were street sleeping not only had a mental health issue, but they had something called trimorbidity, which is it's like a combination of three impacting, intersecting things. They had a mental health issue, they had a drug and alcohol issue, and they also had a physical health issue. So when we're talking about mental health, we need to think broader than just mental health as well, because if you have a septic leg and you can't do your daily activities and routines, that's going to have an impact on your well-being and your mental health. And so they're very much intersected. And so large numbers of people on the street that are sleeping on the street have this trimorbidity. And so thinking about the pre and the post housing of individuals that are street sleeping, we need to make sure that we're looking at all of those aspects and supporting people to address all three of those aspects. But it's very difficult from experience. The Neami Assertive Outreach team working in the inner city of Sydney, they know that there are identified health issues, but individuals' willingness to and capacity to focus on those getting mental health support, getting support around their AOD, alcohol and other drug issues, or getting support for their physical health issues is very difficult when you don't know where you're going to be sleeping tonight, and you don't know if you're going to be safe tonight. And so, again, getting someone in that house allows you to start working on all of those other interconnected impacts. I've done a bit of a review at Neami around when we have a consumer death. Many of our programs, we're working with very vulnerable people, and something that was very sad but very interesting is that the majority of people that have died over the years when they were receiving a service was primarily from treatable, preventable physical health issues. They had a steady decline and ended up in hospital and then passed away. Public stigma would have you think that the homeless population are dying from drug overdoses. That's almost non-existent in the data that I've reviewed. It's primarily more around those preventable diseases that occur. And so we don't have enough of a focus on the physical health, the mental health and AOD support. We focus on getting someone housed, but that's not enough. Far too often I've supported staff where the person has been housed, had a great experience of being housed, but has unfortunately, after a few years of being housed, passed away. It's a really sad indictment on our society that we aren't able to support people earlier to identify those issues and get them supported, so that these preventable deaths are stopping. One other thing I also identified with for people that are street sleeping, that's quite tricky. The systems that they are working in or they're receiving services from are quite traumatic, unfortunately. So I guess systems and services expect people to be timely, to be polite, to be coherent at a time when they're experiencing some of the most difficult times in their life. It's difficult to put your best foot forward when you're feeling the worst. Sometimes systems don't recognise this and identify these as behaviours or people are acting out, or they don't really want a property. And what they really are coping strategies for people attempting to make sense of a really dehumanising experience, and that leads into the need for trauma-informed support for people, for systems and staff and agencies to really understand what's happening in front of them so that they can recognise that and put things in place to support the individual. I just want to talk a little bit about some of the programs or initiatives that are out there that are working. Trina touched on it very briefly around the St Vincent's Homeless Health Team. They're a team of individuals with multidisciplines that go out to people on the street where they are and needed, and they can provide AOD support, they can provide mental health support, they can have nurses to check wounds, and they support people assertively to identify those issues and start working with them as best they can, even when they do not have a house. St Vincent's has been running that service for a very, very long time, and it's promising and pleasing to see some of the other health services starting to have, some of the other health areas starting to have homelessness units and a focus on homelessness, because it's typically been housing and homelessness is sort of separate to health. It's not, they're all interlinked, and health needs to be funding all of their districts to actually have homelessness departments and assertive teams to support people with their physical, mental health and AOD services. So there's good examples there. Again, they need to be upscaled. I guess support programs where people understand mental health work really well. It's interesting, Neami as a mental health provider, we started out as a mental health provider over 35 years ago and have been working in the homelessness space for the last decade or so. The first homelessness teams that I set up were primarily mental health trained staff working in homelessness. And it was really, really powerful to see the knowledge that the mental health workers had, bringing that trauma-informed way to people on the street. When over the years, many of the homelessness services that I've even been recruiting people to, we've then recruited people with homelessness experience because it's a homelessness service. And so we've diluted the mental health knowledge and skills of our teams over time. And some of the challenges that would come up were people not knowing how to, deal with some of those mental health presentations. And so it really is interesting that it's really identified the need that you really need to make sure that your teams are built with that multidisciplinary thinking. Some of our Sydney teams now, we're recruiting health clinicians to support those homelessness teams to actually really navigate the health system, because it's not as easy. Like accessing primary care and physical health is one thing. Navigating your mental health system is even more difficult. And if you're on a DSP, a disability pension, and you've been identified as having acute mental health issue, you'll be able to mostly access care. But if you don't have an acute diagnosis, and you're not you haven't been flagged by other departments, it's going to be really difficult to get a diagnosis to start with, let alone to try and access that care. Another thing I wanted to point out, I'm almost through my presentation, is that something that really impacts people on the street poorly and negatively is organisations' approaches to risk and risk management. At Neami, we've taken an approach to try to shift or to try to reframe risk, moving away from the concept of, say, risk management towards safety and opportunity, because it's about safety for all. Work health and safety is typically about safety for staff. Risk assessments are typically, they do touch on risk to the individual, but they're typically, again, how do we keep our staff safe? And they're not great documents to read. So safety planning, which encompasses risk management, but reframed to safety and opportunity, is a really important way of humanising that process. And it's actually about planning supports for the individual as well as for the workers. And from experience, it creates a much safer and working environment for everyone. So I think there's a bit to learn from there. So moving forward, what do we need to see? Better integrated homelessness and mental health and AOD teams. I had the privilege of setting up the first Head to Health Centre, full centre in Penrith just over 12 months ago. And it's a free walk-in, no referral, multidisciplinary team with, we've got a large peer workforce right through to, mental health clinicians, psychologists and psychiatrists, that people can access care when they need it, and the right care. It's been working great over the last 12 months. It's quite amazing to see the difference that it can make to individuals when they're given some dignity and can access care quickly. And we work really closely with the emergency department in that Penrith area. And we're finding that many people can come to that centre that normally would have gone to the emergency department. They get a much more rapid response, and they're not actually ever really requiring that emergency department response. And so there are models that are out there that are working. So we need to see more of those. I talked about the multidisciplinary teams, I guess the other aspect of early intervention and targeted support is really important for people that are already housed. So there's a program called, the Department of Community Justice have a program called Sustaining Tenancies in Social Housing. It's actually not a very expensive program to run, but it has great outcomes in supporting people that are part of the churn of getting evicted from public housing back onto the street or back into family or back into couch surfing. It's keeping families together, and it's helping people work through the issues and get back on track. And so again, that needs to be just rapidly expanded to the whole state, if not the whole country. Programs like HASI we talked about are great, but again, they target that high end, high need support, I guess, people with lots of complexities. We need versions of HACCI again that will be able to support and people that are maybe not as high on the acuity level for their mental health and AOD issues. All of that being said, to wrap that up, you know, I will come back to, you know, the state election is coming up. We haven't heard much from the Liberal Party about what their plan is for housing and social housing and homelessness. We've heard a bit from some of the other parties. We've heard in the media all the time about the crisis in rental system, the lack of housing, lack of affordable housing. When it comes to mental health, homelessness and housing, the housing is an integral part of getting someone on a trajectory where they can start working on all those other things that are impacting them. Thanks very much.
Thank you, Shane, for another really comprehensive and very illuminating presentation. I think what you said about people primarily dying from preventable diseases while they're homeless or after they've been moved into accommodation is, you know, is something that I wasn't aware of that, and I'm sure many other people on the webinar were not. And you're right, at the end of the day, housing is what we need first and foremost, so that people have somewhere safe and secure to be able to then deal with whatever else is happening in their life. But thank you so much. So we're now going to move into the panel discussion. I do just want to acknowledge that there's some extraordinary comments in the chat function. Thank you everyone for sharing your thoughts, your experiences, your views. We're not going to be able to get to all of them, of course, but they are available there for people to read. And I must say, as I read through them, it just does remind me once again of what an amazing group of people work in the community mental health sector. You know, compassionate, inspiring, dedicated, committed. It's just amazing to read what people are doing, and let's hope that both through this webinar, but through some of the advocacy that all of our organisations are involved in, we can try and shift the dial a bit in terms of availability of housing. So I'd like to now welcome our third panellist, John Mason. Thank you, John, for joining us today. John's going to share his experiences of services over recent times and the difference that it has made to his quality of life. John is a lived experience consumer with Neami National. John, just a bit of background, was a skilled roofer working in his father's business for 16 years when he sustained a serious back injury and became quite unwell. John was referred to Neami's continuity of support program. He subsequently experienced a period of homelessness and was then later referred to the Together Home program, which Shane just spoke about. And that program helped John get back on his feet. I'm sure he'll talk more about that when we move into the panel discussion. And now back in continuity of support program and with the support of a peer worker, John has regained his confidence. So it's great, John, that you're here with us today to be able to share your wisdom and your experiences. So thank you. And can I ask Shane and Trina to turn on your cameras so that we can move into the panel discussion? Great, thanks very much. And John, I might direct my first question to you, if that's okay. So maybe can you tell us a little bit about your experiences and how the service system assisted you to meet your goals?
Yes, like after I sustained my back injury, I got addicted to the Oxycontin that I was taking, and because of that, I really ended up homeless. I also suffered from severe depression, anxiety, and PTSD. I was homeless for quite some time. I was real lucky that I got accepted into the Neami program. They were so great with me. The Together Home program was just excellent. Like, they helped me so much, like, just especially with my confidence, my doctor's appointments, put me in contact with the drug and alcohol counsellor, Morris. he's helped me out a lot. Since then, I've been drug-free for a couple of years now. I'm a lot happier than I've ever been, really. And just getting me confidence in that back now. It's just like, I just really want to thank Neami and everyone from there so much for it.
Yeah, thanks, John. That's great to hear that you had that experience of the service and that it made such a difference, as you say. And I assume that part of that was the various different people that were working with you. A bit, go back to what Trina was talking about with the need for a multidisciplinary team of people to be involved. You had a great experience, but I'm sure that you've got some views about how services could be improved for consumers going forward. Do you want to maybe share those with us?
Yeah, sure. Like the main things I could see is just the speed that things happen. It's like there's just not enough workers out there to assist everyone. There's not enough homes for everyone, as Trina said, and that's the main ways I can really see. Other than that, really, the service from Neami was excellent. It's just that it takes so long to get into their programs and that. Well, not the COS program didn't, but to get into the Together Home program did take quite a while. And like when you're homeless and that, you just feel worthless, and yeah, it's horrible.
Yeah, and that ability for the service to be there when you need it is so critical. And if you have to wait, it just compounds a lot of the issues that you're dealing with. So I think it's a constant refrain that we've heard from all our speakers, that there are some amazing services. We know what needs to be done. We know we can make a difference. There's just not enough of everything that's needed. But thank you very much, John. That was great to hear your experience, and despite the challenges that you've had, to be able to be in a position now where you've got some stable accommodation and really able to look to the future with some hope, some optimism. So appreciate you sharing that with us. Maybe Trina, you could talk a little bit about, because we're hearing about the need for the system to change. What do you think? What part will lived experience, co-design, and co-evaluation play in promoting the sort of cultural shift that we know we need? We've heard John's experience. He's talked a bit about, from the experience of a consumer, what he thinks needs to change. How important is it that we can bring that into the system change that's needed?
Look, the reason we started with people who have experienced homelessness is because it's the old adage, but it's true as today. There's nothing about us without us. Like, there's no point in us designing a big system response for people experiencing homelessness without people experiencing homelessness. So I think Australia has a way to go in our community organising and our co-production. So we're still talking about co-design, which is brilliant. And if we can even get to co-design, we're doing good. But what we've got to get to is co-production. And what we see today with John and Shane from Neami, that's co-production. That's when a person who has experienced something, they've lived it, and now they're working in the service. They're there designing, influencing, and delivering that service alongside the kind of main or funded agency. So they're not just on the outside being asked for their opinion and then you go away and you do it. They're in the tent, they're designing and they're delivering the responses because they're the people who have the most experience. So a question that we've asked people with lived experience is, what role do you think that lived experience, people with lived experience should play in, improving the system, exactly like you've asked? And to be honest, the responses have been very varied. What has been sad for me to see is that the people that we've interviewed that are younger, we say under 23, they are so disempowered. They don't see themselves as having any role. And, John, you talked about that feeling of like not feeling worthwhile or not feeling being part of it. And we just saw so many of the young people just say, sure, why would anyone want to ask me? And it's very sad. So I think it's about empowering people to be part of it, and not doing that in a way that you bomb in and you ask and you leave and you don't tell them what happened. Doing that in a way that really meets the person as a partner, so that you can really have strong integrity about the way that we respond.
Thank you. Thanks, Trina. So Shane, there's quite a few questions in the chat and the Q&A about trauma and the impact of trauma. How important are the principles of trauma-informed recovery in the delivery of your services? Or the delivery of any services for that matter?
Thanks, Carmel. I sort of touched on that a little bit before, but I guess people experiencing homelessness, they're exposed to trauma at every level. And this is what people don't understand. They think, you know, a lot of society thinks that they've got themselves there, it's their fault. That's a lot of the stigma that comes there. But you hear John's story as an example. You know, John was functioning, engaged, had an injury. Do you know what I mean? This is a typical story that happens. Do you know what I mean? You know, unfortunately, the trauma that comes along the way from being homeless is detrimental to your own personal well-being, sense of self, and if you don't have that sense of self, as John mentioned, you know, he's been building himself up, trying to get more confident. You know, that's what having sustainable housing with support can offer you. So if you think about from the base level, when you're on the street, you don't know where you're sleeping. It's not safe. Public are walking past, you're hyper vigilant for your own safety. You don't know if your belongings that you have will be there when you come back, when you go to get some food. They might be chucked out by a council that's not very considered, not supportive of homeless people being there, or it might be someone stolen their property, or it might be, you know, there's lots of reasons that can happen. So right there on the street, there's a base level of hypervigilance and fear that can come for people. And then, you know, I talked about before about the, you know, being at that point and then being told to come now and meet us at this time, or well, you have to have a phone number that's maybe stolen, or the phone's stolen, or it's lost, or it's broken. If someone is a bit dysregulated in their thinking, or they maybe, you know, are worried about their own well-being, they're probably not going to turn up for an appointment at the exact time that you've asked them to. And that's seen as they don't care, it's not important. But the impact of that can be that the person can be taken off a housing register super simply, and they get a black mark across their name. We tried to help them and no, they didn't. So the way we approach it, without having that trauma-informed approach and understanding of the experiences people are going through right now as they're seeking services, you know, you're not going to be able to have that compassion to actually ask the right questions. You know, do you have capacity? You know, what's your memory like? You know, do you need support? Do you need a reminder? You know, those kinds of things. And not to bash systems fully, they're also under-resourced as well. You know, systems are under-resourced, and that's that thing, just needing more support. But trauma-informed practice is really critical in supporting people.
Yes, absolutely. Thanks, Shane. So it's been a great discussion. It's a shame we don't have more time. We always say that with these webinars. They do really bring out so many issues that people are very keen to discuss and learn more about. And, you know, we had over 200 people who registered, who attended this webinar. We had many more register, but we had over 200 people who attended, which is just really quite extraordinary. So maybe, John, I might give you the opportunity to answer the final question if you're willing. And it really is to, you know, if you had one thing that you could get the New South Wales government, whoever that might be after the 25th of March, to do to better support people who are homeless, what would that be?
It'd just be to make more homes available, like, and try to get the waiting list shortened. That, yeah, it's just so hard, like when you're on the street and that, and yeah, like just basically, yeah, the time it takes. That's about all. Sorry.
No, I think that's a very wise and sensible place to land. More homes. That's what we need, more homes. Look, thank you very much to our panellists, to John, to Trina, to Shane. Really appreciate your time, the wisdom and experiences that you've shared. I think it's been, judging by what's in the chat function, it's been very much appreciated by the audience. Thank you to all of the participants for sharing your experiences through the chat, your questions. We will try and respond to as many as we can. I can also let you know that the panellists have agreed to share their presentations, so we'll be making those available on our website, and also on our website. The recording of this webinar will be available in a couple of days, so if you want to tune in and listen to it again or send it to someone else, you'll be able to do that. We'll also be distributing an evaluation form. I know those things are annoying, but if you could please fill it out and return it to us, because it helps us demonstrate to the organisations that fund us that the work we do makes a difference. So it's always great to get those evaluations back. So look, thank you very much. I think this is a really, in many ways, a very distressing topic to be talking about, because we all think we should be able to do so much better as a society than what we do at the moment. But we also know that change won't happen without all of us advocating for it and working in the sector and trying to do the best we can to both support individuals, to share our experiences, and to advocate for systemic change. So thank you very much, and look forward to hopefully seeing you at another MHCC event. Thank you.